So we're back here with part two with Nach, and we're going to talk a little bit about some of the things that he has discovered with brace management versus surgical management versus looking at something in only one data point, such as a Cobb angle and some of the pitfalls. Take it away. What do we need to know?
So during this break, we were chatting when we've been in terms of whether Cobb angle is the right measurement, what we need to look at and all that. I think from my experience, Cobb angle, what it does is it's a 2D measurement of a 3-dimensional deformity. So the Cobb angles are normally measured using an X-ray, which is a 2-dimensional representation of a 3-dimensional deformity. So Cobb angle gives a very good indication of the magnitude of the curvature and the apex of the curvature, but it doesn't really give you a lot of information in terms of the functionalities of the spine and how this child grows, and that's very important. And that's what governs the way that the clinical management is sorted. So I've been involved with 3 of these Cochrane reviews in terms of exercise intervention, in terms of bracing, and also in terms of surgery versus conservative management of scoliosis, particularly in adolescent idiopathic scoliosis. I wouldn't go into talking about other types of scoliosis. So does bracing work? There is enough evidence out there, and there's been few clinical trials showcasing that bracing does work. And the issue here is these bracing studies have looked at mainly smaller curvatures. And when the curvature goes higher, obviously that patient needs surgical intervention to stop the curve getting bigger. In terms of exercises and what my colleagues in Serbia and ourselves, we are looking at is stroke intervention in terms of exercise intervention. There's also other types of intervention, scoliosis specific exercises, which are being done. And majority of the cases in continental Europe and rest of the world, people do believe in these exercises and these conservative management. But here in the UK and mainly in the US, surgeons tend to wait and watch or go for surgery. There's very little uptake in terms of conservative management for adults in idiopathic scoliosis. I think it is changing. And from my conversations with scoliosis surgeons and spinal surgeons in the recent past, in the last 3, 4, 5 years, there is a definitely change in attitude in terms of conservative management versus surgical management.
So I'm gathering from your statement that smaller measurements, along with other types of clinical variables that are there to give you the reason to, one way or the other, decide on surgery versus quote unquote conservative management that might be more under the guidance of like a physiatrist, a doctor of rehab medicine, for those that don't know what a physiatrist is, as opposed to podiatrist. I'm going to give you a real case. My daughter had triplanar scoliosis. Here's the interesting thing. She was getting ready to go to high school. And so very awkward time to have that surgery potentially done. And I want to say, if memory strikes me, and I probably have to go back to the notes, but she was at Cobb somewhere in the 33, 34, and you could see that, there was that frontal plane, et cetera. She was not having pain. That was the interesting thing. So now I'm going to give you the $1 million question, because I do surgery. I also do conservative management. I've done the best of both worlds. I'm not one, though, that will necessarily jump to surgery. I had an ACL. Okay. It was deficient. I had it, it was a bucket handle tear, and I had that flap taken off on the meniscus, the whole medial meniscus, right? 80% is gone. What I've done and what I have read subsequently in papers is that if you manage and do strength exercises, I do not have that power of a kick on a soccer ball that I do on my right. However, I will tell you, I am able to ski double X black diamonds. A different sort of muscle contraction occurring there versus if I was a professional soccer player, which I'm not. I just go out and have fun. But what that told me is that I saw one of the top orthopedics, and he was recommending recon after my second injury, which was basically doing standing broad jumps in a Gold's Gym class. And there was no need to do an airborne exercise. So that's yet another thing is I got caught up in the spirit of like, oh, you're having a relay race, and you know, everybody was rah rah, and then subsequently I re-injure my knee. But I've been able to perform at a fairly high level in terms of stability with that type of program. So back to my daughter, and if we took our little retrospectoscope, not too concerned that it limited her height. I think she's about 5'4", but it does close down those plates. Aside from that, though, how does one guide parents and an individual, let's say if they're older, about whether to take the surgical leap if you're not having any problems? That's kind of, I think, the $1 million question.
That's what, as I just mentioned, there is definitely a clear change in attitude in terms of surgery, and the surgeons, both here, this side of the pond, and also in North America,